All right, good afternoon, everybody. We're excited to welcome Dr. Grant Garcia to our webinar series today. Dr. Garcia has been practicing as an orthopedic surgeon and sports medicine specialist at Orthopedic Specialists in Seattle since 2018. Today, he'll be sharing some information on cartilage restoration techniques, meniscus transplants, and the use of biologics. So as I've gotten to know Dr. Garcia over the last few years, it's become clear that he's always looking to innovate and implement the most cutting-edge treatment options for his patients. He's also a huge supporter of physical therapy and has been a great resource for therapists in the Seattle area in general. So we thank you for that, Dr. Garcia. If you have any questions today throughout the webinar with Dr. Garcia, please feel free to type them in the chat feature at the bottom of the screen, and we'll be able to read those to the audience at the end and let Dr. Garcia answer some of your specific questions, and we can go from there. But today, I'm extremely excited to hand over the floor to Dr. Garcia as we learn a bit about what he's doing to push the envelope with sports medicine and in the musculoskeletal system. So thank you very much, Garcia. The floor is yours.
Well, thank you guys for having me. So we'll get right into it, and then we'll try to keep on time as well. So today's talks, we're gonna do a little bit of biologics and then how we integrate that with cartilage preservation, which is sort of a hot topic. And people don't get to hear a lot of sort of down and dirty information on this. And then meniscus transplants. And then we're gonna talk about what's the hype with this. All right, so let's try to get this moving. All right, perfect. So disclosures are here. And then a special thanks to anybody that does any research on meniscus and cartilage transplants will see this guy's name. This is Brian Cole. I worked with him at Rush, so I was able to get some of the special techniques and have this newfound love for cartilage and meniscus. And he really is to thank for that. And he's probably one of the best in the world. So I'm very thankful to have worked with him. So what are the objectives today? So we're gonna do a brief review of biologics. Again, indications for different cartilage procedures, and then we're going to review cartilage transplants in general, and then we'll review meniscus transplants. So current landscape, this is 2021. You have orthobiologics options, and we don't have extensive time to go into all of these things, but just a brief overview. You have the cytokines of the proteins. This is something you heard about with Kobe Bryant going to Germany. It's less common in the United States. It usually requires a number of different injections. It's pretty expensive, but it's an option that people have. And there's only a few states that allow it currently, and most of it's in Europe. PRP, which we'll really briefly touch on, there's two major types, leukocyte rich and leukocyte poor. And then you have the stem cells, which you hear about in sort of a hot topic. You have the ones taken from your own body or autologous, so that's marrow, adipose. And then you have allogeneic, which is adipose, marrow, and you can also have the cord blood. Cord blood is the one you guys hear about most with other clinicians because that's the one you can have in a freezer and then just put in a patient in the office. So what are orthobiologics? They're substances found naturally in your body. They help heal more efficiently. They're matrix materials, so bone grafts and autologous blood. Then you have artificial matrix materials, and they have growth factors, mainly the PRP, and that can really help with the improvement in tendon healing or in decreasing inflammation for cartilage issues. And then they have BMPs, and then for stem cells, you have certain types as well. So what's marketed to surgeons? Well, everything's marketed to surgeons, but in general, these are sort of this is from a 2018 conference and showing what was marketed to surgeons. If you see in the red boxes, those are sort of the most best studied. Level of evidence is high on those. And these are the ones I use majority in my practice. I've tried some of the other stuff as well, but this is sort of the mainstream, what we have, best data type of thing. I'm a data-driven person. You know, I like to try cutting edge stuff, but I also want to make sure that it's going to work appropriately and be safe for the patient. So here we go. So surgery and biologics. So how do we take an OCD that looks like this? This is the scope. Combine it with bone marrow aspirate you see on the bottom and take a fresh cartilage from there, soak that in there and turn that into that plug right there. So we're going to talk a little bit about that today. And then you can see this, the view on the afterwards. That's a diagnostic scope after the plug's been done. You can see it's well integrated in and sort of save this young person's knee. So these are the PRP options. And again, not all PRPs are placed the same. So it's important that if you go to a surgeon or any doctor that they know sort of the differences in these. So you have the pure PRP, which we're still working on what that can benefit. And then you have leukocyte rich and leukocyte poor. If you see, both have a lot of platelets in them, but the leukocyte rich ones have a little bit more platelets. So that's better for tendon healing, but they also have more white blood cells. So they cause an inflammatory reaction. So you don't want to inject those in somebody with arthritis who already has a pretty high inflammatory reaction. You just want to give them the benefits of the platelets. So you work with the poor. This is a very brief study, and we're going to go over this very briefly, but basically compared a bunch of different things, leukocyte rich, leukocyte poor, and then regular blood PPP as well. You can see here on the bottom right, really the mainstream. And again, I know not everybody here is a clinician or a physical therapist on this call, but You can see the two boxes, anti-inflammatory, inflammatory. LP is leukocyte poor. Those have anti-inflammatory properties, higher anti-inflammatory. So that's the one we want to use. We want to decrease inflammation. So cartilage defects, arthritis, etc. Inflammatory, you can see the ones that have a pretty high boost in inflammatory properties, that's the leukocyte rich. So those are the ones you want your tendons to be frustrated or be upset with the injection you're doing so they heal. And so that's what we do for tendinopathies such as patella tendon, quad tendon, lateral epicondylitis, you name it. All right, so that's the brief over that. And let's go to the fun part of the cartilage transplants and stuff. So cartilage preservation surgery, what does it require? So first off, you have to be really patient. I mean, these are not patients that come in, it's first time, it's easy, you're done, and that's it. You need to look and be okay without perfect. So understanding that cartilage procedures are very useful, but they're not good, they don't work for everybody. Some of these surgeries, they have a 70–80% success. Again, so it's important to understand this is not a perfect indication. I know most of my patients do really well, but it's not perfect. 30% complication rate, and we'll get into this. Most patients come in with more than one surgery. So, most of my average patients are about 3 surgeries previously on the knee or wherever else we're taken care of, and you have to be able to sort through that stuff. You have to look outside the box. Do they need revision of their ligaments? What cartilage lesion do they have that's actually causing pain? Sometimes they have multiple areas, and not all of them need this large surgery. So the biggest thing is figuring out what these things are. And I'm going to continue to harp on this in the first part of the lecture about cartilage preservation. So what is needed? So this slide on the right is a really good summary, high quality slide. I'm not going to go over too much, but if you guys look back on the video, you guys can take a look at this again in more detail. And we're going to go through this throughout the lecture. You need a coordinator. So I have my own coordinator for all these cartilage and meniscus transplants that just deals with this exclusively. When you find a patient that's indicated, you put them on the cartilage transplant list, and then you wait for a match, similar to you do for any type of transplant. For cartilage, once we get a match, you usually have 28 days to implant it. So you want to make sure you get this taken care of promptly. Meniscus transplants are a little bit better. You have more leeway, usually 6 months or more. But here's the kicker. You got to be comfortable with other procedures. You can't just be doing these things and you think you're going to have good results. You have to be comfortable for ACLs, revision ACLs, high tibial osteotomies, meniscus transplants, DFOs, tibial tubercle osteotomies, MPFLs. It seems like a lot, but if you don't know how to do all those things, you shouldn't be dealing with this stuff, because it needs to be, you need to do this as a combination to give patients the best possible results. So, well, why don't we treat all cartilage lesions? Well, not everybody needs to be treated. Just because you're a surgeon doesn't mean you do surgery on every single person you see. There are a lot of defects in the knee that we don't treat. And again, I have pick and choose my things. I have patients that come in my office all the time asking for cartilage transplants, and a lot of them don't need it. So it's important that you figure out the ones that need it and the ones that don't. So these are just 2 studies that showed that certain lesions can be left alone and they do just fine. So my first indication when I see a cartilage patient is not that I'm going to give you a cartilage procedure and make you better. It's I'm going to see what happens with non-operative treatment. And that's especially where PT comes in handy. So it's, again, that's why we work so closely with them. This is a big problem I have with certain people doing surgeries on people with cartilage defects. So the ACL with cartilage defects are notoriously a problem for certain surgeons. So this is a study showing 644 patients. They had ACLs with full thickness cartilage defects. 129 of them were debrided and 164 were microfractured. Why not microfracture? It's super easy. Let's just do it when we're in there. Well, the problem you have is that the microfracture group did significantly worse. And the conclusion was that if they have microfracture and ACL combined, they have very negative outcomes in comparison to just debriding. So my number one thing when I see a cartilage defect in an ACL is I leave it alone. I literally just clean it up and leave it alone, and the patients do really well. The number of people that I've had to transplant or do something crazy after I found a defect that was asymptomatic is like in the 5 to 10% range. So you do not need to get microfracture of your defect or some cartilage procedure instantaneously. Well, then who do we treat if you're not taking care of anybody? Well, that's not true. It's just that those are the patients I was trying to explain to you, that you can have non-operative treatment and people do well. But there are a lot of people that still don't do well with just watching it. And so this is where symptoms are important. You need to have symptoms in order for me to make you better with a cartilage procedure. Remember, they can be subtle. Patients come in with swelling, they come in with pain, they come in with locking. This is a young 26-year-old patient that needed a combined medial meniscus transplant and a medial cartilage transplant. He's doing really well right now, but again, you can see not a great looking MRI. Also had a chronic ACL, which is why we want to take care of those ACLs more promptly. So damage secondary to meniscus, you got to look at those things as well. This can all happen suddenly. This guy's had this probably for 5 years, all of a sudden started having really a lot of pain, a lot of locking, a lot of catching. And it was actually a physical therapist. So, you think they know more about their knee, and they do. But again, this is someone that came in, had no problems until just recently. And all of a sudden they had a tipping point where I had to intervene. Well, why would you ever intervene? I mean, does it matter? There's no point. I don't really understand. Well, it does matter. So cartilage repair can prevent progression of knee arthritis. So if you start to have symptoms, this is when we want to start intervening because people want to prevent that arthritis in your knee. And that's what it's called about cartilage preservation. So this is 32 patients, 16 had treatment and 16 had no treatment. And they had 6-year follow-up, and these were pretty moderate sized defects. The non-operative group had significantly worse functional outcomes and more severe osteoarthritis compared to the cartilage repair group. And these are identical cartilage lesions. So the mainstream is, I've showed you a lot of different data. If you start having symptoms, we want to think about taking care of this because we don't want damage to your tibial cartilage or your meniscus, or you turn in someone like this on this bottom page, meniscus is completely gone, and so is the cartilage, and it needs a double transplant. So what's my algorithm? Well, this is pretty intensive. And again, each one of these things is a thought process we go through with the patients. So debride, first season athlete, new onset mechanical symptoms, always debridement first. Microfracture, again, I do very little microfracture now. It's just really, it's not as great of a procedure as all the other options I have, and it can damage certain secondary procedures you do. Biocartilage de novo, we won't go into that too much because it's for smaller defects. You have transplants of actually taking cartilage from the person's regular knee and then putting in other parts. You have MACI, which we won't go into in too much detail, but we do a lot of those as well, mainly for patellofemoral joints. And then you have cartilage transplants we'll talk about today. So what do you want to think about? Well, how does this all relate? Well, you need to have a good physical exam, history, MRI, you need to look at alignment, you need to put it all together. And all these treatments are customized. Every patient I see gets a different treatment option, and we talk about all these different things. You need to be aware of all these things to get better results. So what is the issue? And I think Mark and I were talking about beforehand. Why do we not have more people doing this? Well, first off, it's training. If you don't see these in training, it's not really something you can just jump into. It's very complicated. There's certain things you have to learn how to do. And if you can't just start doing transplants and not know how to do the other things we talked about. And as you can see, this sort of conundrum you run into where you have to do about bone marrow lesions, ligament injuries, and all these other things, it becomes pretty complicated. It's time consuming. This is not like your ACL patient that comes in and then, and if you see them one visit, you think they need surgery, you kind of talk to them about it. This is 2 or 3 visits. They come in with a stack of notes from previous surgeries they've had that have failed. This is a lot more time consuming. And so some doctors don't want to go after that task. And many of these problems, sometimes they require more than one surgery. Some of mine are stage surgeries, some of mine are 3 or 4 hour surgeries with combined ligament reconstruction. So it's important to know that. The other thing is, while this sounds all sexy and nice, there's just not that many patients out there that need this. We're not talking about millions of people running around. It's not like a regular ACL. And so if you're not a referral center like I am for seeing these things, you're going to see them once a year, twice a year. And it's just not as good in terms of your technical skills to do that. And then again, the more previous surgeries, the worse the outcome. And so people don't like to see, they've had 3 or 4 surgeries. Some surgeons get nervous about having to do a revision surgery on somebody. And so these are the reasons that this is not as talked about, or sometimes surgeons aren't aware of this options. So again, this is going to be harping back to the thing. You've got to evaluate everything: malalignment, meniscal deficiency, and then again, looking at different options for the cartilage defects. You can see the Venn diagram on the bottom right, looking at alignment. So you got to understand alignment, and you got to correct it with any of those procedures listed. That's a DFO, HTO, or tibial tubercle osteotomy. And then you got to correct instability. And then in the end, you can correct the meniscal or articular defect, but you got to make sure that all those things come together. Now, sometimes you're lucky. And again, there's a number of patients I see that just need one thing done. But if you don't check those other things, your grafts will fail, and then your patients will be unhappy. So what's the spectrum of treatment? Well, you go from the most common here with debridement all the way down to cartilage transplants and MACIs, which we'll talk about briefly. You can see the tissue quality that you get from that. One is fibrous tissue, so it's not that good a quality, which is why it only is good for small defects, versus hyaline cartilage, which is really good quality and has much better longevity. The skill level required is on the left side is much easier to the right side, which requires more skill level. And again, the 2 most commonly done ones you can imagine are the microfracture and the debridements. And then you can see the numbers up there. So, well, why would you just do debridement? Well, debridement does work sometimes. We've already talked about sort of leaving these alone. Well, if you bevel off the area, you can actually improve the contact forces and reduce the chances someone needs another transplant at a later time. So again, everything I do is a stepwise process to avoid a transplant unless we need to do it. So we do a diagnostic scope for every patient. You're going to hear me harp about this again because not everybody does this. But you want to evaluate the lesions because they're always bigger than you think. You'll hear someone say, I've got a little tiny defect. It's about 6 millimeters, so about this small. Then when you get in there, there's a bunch of lumped off cartilage, and it happens every single time. I don't think to date I've gone into a diagnostic scope and not debrided more than the defect size you saw. The cartilage around there gets undermined and it's much larger. So when someone tells you you're not indicated for a certain procedure, they should do that after you have the diagnostic scope. They can't really make much indication by your MRI alone. And again, you don't want to microfracture these defects. So you just clean them up, you watch them, and if they need something later, they'll tell you, and you'll proceed with that certain procedure. Well, does chondroplasty work? Well, it does work. Here's a study of NFL players, 52 athletes. Again, follow-up was almost 6 years. There was no correlation with success rates by age, lesion size, location, or position. But I can tell you right now, look at this, microfracture, 4.4 times less likely to return to play. Just clean up the defect. Don't poke holes in it because it seems easier. Because remember, someone pokes holes in your defect, you should really be non-weight bearing for 6 weeks. And that's not what usually happens. And again, 67% return to play at the NFL. This is the highest level possible. So that's pretty good numbers. And again, James Andrews is pretty good. He does a lot of these different athletes and has been known for this stuff. So this is MACI. And this is just briefly looking at the results. This is mostly, I use this mostly for patellofemoral joints. And you can see here, MACI or ACI versus microfracture, much better scores. And then again, you had 12 months. It takes a little longer to recover from a MACI in terms of the full return to sport. So 12 months versus 7 months of microfracture, but the microfracture deteriorated after 2 years. If I have a surgery that deteriorates after 2 years, I'm not doing the surgery on the patient. And again, you can see here, high return to sport, 73% return to sport. These are higher level patients. It's not someone that wants to get back to walking. This is basketball, baseball, running, you name it. So 73% is pretty good for a detrimental injury. And this is just one more brief study talking about MACI. So people always talk about MACI and they ask, how can I get better? What's the options for me? Here's 58 patients. Most of them had to have a tibial tubercle osteotomy where we kind of realign the knee. 8-year follow-up. These are challenging. This is a challenging patient population, probably the hardest one I deal with. 88% satisfaction. That's pretty freaking good. I would love to have that all the time. No microfracture patients, 91% at 5 and 10 years. Again, you're going to hear this word. With microfracture before, you damage the underlying cartilage, bone cartilage, 43% success. So I try to do microfracture as little as possible. I debride, and if I need something, then I do a MACI. That way I don't burn this bridge. Again, another one of those really good summary slides is these. I love these sort of the color-coded ones they have. There are 3 types of patellofemoral cartilage patients. There's the patients that get a defect from direct trauma, and those still sometimes need tibial tubercle osteotomies. And you can see the success rates over here. There's ones that have dislocating kneecaps. That's where you need to do other things. And sometimes they have cartilage defects that need to be addressed. And there's others that just have a really bad alignment and they just overload the kneecap. All of these need a tibial tubercle osteotomy for certain different reasons. And then all of them have cartilage defects. So there's certain ways you correct each defect depending on where it is on the patella. Let's go to more of the simpler stuff. This is the condyles. So again, transplants of your own cartilage, very small plugs. You can see here 96% success versus microfracture. Microfracture not very good, 52%. So let's get to the fun part. So cartilage transplants. So they harvest them from patients within 24 hours of passing away. It's aseptic processing, full PCR testing. They check for all these different things, and then they're prolonged fresh, and the goal is implantation at 28 days. So how do we match them? Well, this is a match of one of my patients. You can see here how the numbers they give me and how I try to match them up. They used to use x-rays, now we use MRIs. If it's a trochlear defect, it's a little more complicated, but again, similar process. Diagnostic scope, submit the MRI and the operative notes, submit for insurance approval, and then submit the graft company. And when the graft is found, we implant the graft within 28 days. So here's a little fun. We're not going to go through this too much, but you can see me. This is if any viewers gets kind of nauseous of surgeries, maybe close your eyes for a few minutes. But here we're going to show you surgical procedure. This is a medial femoral condyle cartilage transplant. The patient also had to have a meniscus transplant. You can see that I'm marking out the area. We have a pin we use, and we're going to kind of go through this quickly. And then I'm going to mark that area of the defect. You can see the defect over there. And then we core out that area, just kind of like woodworking plug. And then this is the patient, this is the recipient, so the plug that we got. I'm going to mark it out. Then I'm going to core it out. And then you can see we're trying to get that out carefully. You've got a nice plug there, and then in the back table, one of my PA, or at the surgical patient, my PA is cleaning the hole and making sure it's ready to go. And then we're going to mark out the depth of what we want for this. All right, and then we're going to sort of get this cleaned up, get this plug ready to go. Again, this is a subtle process. If it's not perfect and you start malleting this thing in, you can damage the cartilage. So you want this to be sort of press fit in perfectly, and then you want the contour to be nice. So you got to make sure that it matches up identical. And this just takes a little technical skill. We put some PRP or bone marrow aspirate into that plug to help it integrate. You can see the plug hole is there already. And then, you do a little bit of praying at this point, making sure that this plug goes in nicely. These are very, very gentle taps, because you don't want to sink this plug in too far either. And you can see, look at that, perfect contour. And then we'll scope that as well. And then we finished off the meniscus transplant. So that's how I do it. So again, what are the results? So 43 patients, these are pretty good athletes. Again, patients that didn't have any osteotomies, just transplants alone. 88% return to play, average return to sport, 9.6 months. So it's important to know this is not a 2 or 3 months recovery. If they were greater than 25 or symptoms more than a year, they had slightly lower return to play. But again, I do plenty of patients over 25 that do quite well. So this is a little bit newer study, 149 knees, highly competitive, highly trained. Almost all the patients I see are in that well-trained category in Seattle. So that helps to have that sort of patient population. So 6 years, 75% return to play, 91% satisfaction. So this is important. People always ask, how long is the graft going to last? 91% at 5 years, 89% still intact at 10 years. Now, the biggest thing here on the right-hand side is what I want these patients and the PTs to see. There are complications that occur. The 30% complication rate is not a failure of the graft. Most of the time, it's a little tiny piece of cartilage that tears off, and that's a diagnostic scope. So most of these patients you can see here had to undergo an arthroscopy, and that's just to clean up the cartilage. There's about a 9.4% failure of the graft. Unfortunately, when that happens, a lot of times you can do a revision, but sometimes they need to be converted to different things. Now, again, these are all different age ranges. Here's another study. This is 13 athletes, high-level athletes, return to sports, 77%. So it's pretty good. These are patients that want to get back to high-level stuff. The reason the other ones didn't return to sport is they eventually graduated from sort of college level. And this is real. Life circumstances and fear of re-injury are the most common reasons in my practice that patients don't go back to a certain sport they want to do. I usually release them to everything they want to do, but the return to sport is 77% because some patients are worried about going back. What's the longevity? So here, this is really important. And so I tell patients this number because this is what they care about. How long is this going to last? I don't care if I want you to do a good job, but I want to know how long this is going to last. I don't want to have to deal with this. I'm 25 years old and I want to get back to everything I want to do, and I don't want a knee replacement. So I give this data, 91% at 5 years. I usually say 85% at 10 years and around 75% at 15 years. And again, this is even older. This is 2012, so we've gotten better in terms of the techniques and the implants that we use. The system you saw me using is only about a year old, so we keep getting better and better. Again, this one's looking at comparison of all the different things. You can see return to sport for cartilage transplant, that's OAG, 88%. Now, the 82% for MACI is a little bit off because these are patellofemoral patients. The results of them are a little different than the cartilage transplant patients because it's a much harder patient population. So that's actually a really good number. Microfracture, you can see 58%, but look at the return time. Microfracture and cartilage transplants are the same return time, even though your surgeon may tell you it's super quick to get a microfracture done, but you're gonna have much worse results in terms of return to sport. And this is looking at, again, focal defects, 160 patients, reoperation was 39%. So it's not an easy surgery you should go through and have this and say, okay, it's gonna be simple, I'm gonna be done with this. But survival rates, 86%, 81%. What were the failure predictors? So high BMI, so people over a certain BMI of 35, I won't do this surgery until they unfortunately have to lose the weight. Longer symptoms, and if you have a number of surgeries. So those patients with 4, 5, 6 surgeries, they have good results, but it's not as good as someone if you catch them earlier. So that's why I try to encourage, and hopefully these talks can encourage surgeons not to go and microfracture 6 times in an attempt to try to save the person's cartilage defect. And again, this one is combined. So what about those ACLs? You told me you never do them. Well, sometimes you do, but usually you do it after the first ACL if they've had a failure. So again, here's the survival rate. When you have a need for a cartilage transplant with an ACL, 31 knees with ACLs and cartilage versus 62 knees with no ACL. They had the exact same results with done with the proper reason. So again, as long as you correct the other issues and you have a cartilage transplant at the same time, patients do just as well. So here are the problems and how we fix them. We're not going to go through all this because again, we're for sake of time. So let's get to the next hot topic. This is meniscus transplant. And again, I'm just going to check the time, make sure we're doing okay. Perfect. So we're on there. So again, this is a way to slow down the arthritic changes in people with meniscal deficiency. This is not a transplant that's going to stay there forever. This is a scaffold. So it's supposed to help cushion the knee and reduce the chances you damage your cartilage. So what are the indications? So previous meniscectomy, more than 50%. So this is where people get confused. They think your entire meniscus needs to be taken out. But I have done plenty of patients in the 30, 40% mark that had a pretty good, well done meniscectomy, and they start having pain. That's usually called meniscal deficiency syndrome. So patients with pain and discomfort associated with this meniscus deficiency, patients who undergo ACL for increased stability, this is really important. If you have no meniscus and it hurts, and you have your ACL out, I would almost always do a transplant. There's a ton of data now that shows that it increases the stability of your ACL and protects you. A lot of people don't do this because obviously it's hard. I mean, we're talking about a 1 hour procedure versus a 2.5 hour procedure. And especially if you're not doing transplants, that's a whole nother thing to tackle. And again, you can reduce arthritis development in athletes. So what are the indications? So you want to have an absent meniscus with pain and swelling. Again, this is not a preventative thing. You don't just do this because you saw no meniscus and then you think, okay, that's gonna be great. The number of people I've had to do a meniscus transplant on and I did a previous meniscectomy is almost 0. So these are people that have had this and then all of a sudden, after like 5, 10, 15 years, maybe they need it. But this is not someone that I transplant every single person I cut their meniscus out. And again, we try to do as little as we can, but sometimes we can't prevent it. It's not a pre-symptom procedure. Now here's the important part. Correctable comorbidities. So BMI less than 35, good alignment or alignment that I can correct, a ligament that I can correct, or cartilage that I can correct. And the last thing is expectations. Patients come in asking for a meniscus transplant because they think they want to go back to when they were 15 years old and run, do whatever they want to do. No, this is a pain reducing procedure. I'll let you do a lot of sports afterwards, but I need to have the right expectations. You're gonna be a patient of mine for the rest of my career. And so as a result, I need to make sure the expectations are set properly. Well, why do we do transplant? Well, here's one with an intact meniscus. You can see the blue is sort of less pressure on the tibial cartilage. When you take a meniscectomy, look at all the cartilage damage you can prevent, you can add. That deep red mark, that's basically like a pressure thing. You can see that in some of those sleep commercials. They show you sort of where the pressure sores you can get. When you add a transplant, you can see you almost return the regular forces back to the knee, which is quite impressive. So this is why it's important and why it can help patients with those types of pain problems. Well, how do we size them? Again, using MRI, we match the size of the patient. I do a diagnostic and then I submit for this. I give them MRIs, operative notes, clinic notes, do again, the insurance approval. Again, it's much easier than a transplant of a cartilage because they're frozen. And so I can schedule the patients within 6 months. So that's a lot less stressful. The problem you have is a lot of my patients need a combo. So they need meniscus and cartilage. So they're at that sort of mercy of the cartilage portion. And you can see these are the parameters on the bottom. This is one of my patients and how I match them as much as I can. And again, less than 10% is satisfactory for your match. So we want to do an index scope. You keep hearing me say about this. I do a scope first before I do any transplant. Look at those x-rays up there. Looks pretty good, right? Maybe a little bit of arthritis. Well, you get in there, not good. That patient's not getting a transplant. They are bone-on-bone arthritis, and they were able to, they look like they were much better on the x-ray alone. Don't rely on old MRIs or old scopes. I'd like to trust everybody, but I don't. After a year of a scope, it's no longer valid to me. I want to go back in there and look at it again. This is a very long surgery for patients to recover from. This is a surgery that requires a lot of technical skill. I'm not going to go through and do the procedure for somebody if it's not going to work for them. I want to make sure my patients do well. That's really important to me. So you want to avoid the bail during surgery. And again, this helps insurance approval. This is it's not expensive for the patients, but it's expensive for the insurance companies. So they want to make sure that this is something appropriate. And my approval rate's pretty high because I do all this stuff. So there's many times we do a meniscus transplant and we go in the diagnostic and I find a hole in the cartilage and I have to update the surgery order. So that's important to know. I've heard too many problems of people getting a transplant of one thing or the other, and all of a sudden they need to have 2 extra things, or they were told, oh, something wasn't covered. So you want to make sure you're totally set up with the diagnostic scopes. You have all the instrumentation and all the transplants you need to help this work. And that works 20% of patients, you'll be surprised. And so that's why it's important to do the diagnostic scope. Again, another nice color-coded diagram. You guys can go back on this later. And this sort of goes over everything, the different techniques. I do bone plug and bone bridge, which I'll show you briefly. So for the sake of time, we'll go through this briefly. So I want to show you guys how I do a lateral meniscus transplant. So you can see here, I'm doing a little notchplasty so you can see the back of the knee. And again, hopefully the patient seeing this will appreciate this as well. But basically what we're doing is we're marking out, we're going to cut out. Now this is a cadaver, so they have a normal looking meniscus. I don't do that with a normal looking meniscus. And then you're going to remove the meniscus in the back as well. Okay, and then you got to trim it out and clean it up and get the whole base ready to go. Then this is a slot technique. So I do this for lateral meniscus only. And I'm going to make a nice slot and a trough with my shaver. And then we're going to prepare the meniscus. This is the transplanted meniscus, and we're going to cut it in the dovetail fashion. And then we're going to kind of set this up. And then I'm going to use my pin here, and I'm going to draw 2 pins. And then what we're going to do is we're going to take this out, this instrumentation, and then we're going to sort of core out and make a dovetail, a slot, so it fits in. It's just like woodworking, okay? Good, and you can see here, I'm sort of making that trough in the meniscus under arthroscopic visualization. And this is the passing instrument that I use. So we'll pass these needles through. And this will be how we pass the meniscus through the knee. So you can see I've got 2 passing needles in there, and then I've got the slot. Go back over there. Let's see if we can get this going again. Sorry about that. So you can see this is the part, again, everyone holds their breath. So we hold our breath and push, 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 try to get that meniscus in. The meniscus is flipped. It slides right into the slot, and then you've got to reduce it. So then again, everyone's a little bit of holding your breath, pop right in there, and then you're going to fix the meniscus. So you fix it in the bone first, and then you'll fix the meniscus to the capsule with a bunch of different sutures. And then at the end, you got a nice looking meniscus transplant. All right, so we'll go on to the next one. So I'm not going to belabor this too much, but I'll show you guys how to do a medial one too. So as a patient of mine, this is a little bit even more arthroscopic. You do a little tunnel, and then you have this special device that goes like this in the back of the knee, and then it flips, and you can actually make a reverse plug for this patient. And you see we got a little hole there now, and it's a sunken hole. And then I'm going to grab that passing device from them in the knee. And then there's the meniscus. So it's a different type of meniscus transplant, not a big thing. It's a plug technique. And you can see here, we've got all that stuff set up. And now for the fun part, don't tangle any of the sutures. Okay, easier said than done. So now you're going to take all this and you're going to load the meniscus up there. You're going to pull one of the roots, and you can see the meniscus is in my PA's hand. And look at the size of that portal, not very big. So you want to make sure you do this arthroscopically, and then you're catching all these things out the back of the knee because you're going to tie the meniscus to the back of the knee. Again, no tangles. Everybody crosses their fingers. You hold your breath a little bit, and boom, get the meniscus in. This is where you got to make sure you know what you're doing. Then you're going to gently pop that meniscus in. You can see pop right there. You've dunked the back root, and then you're going to pull the meniscus in. And you can see we've marked the P. And then I'm going to fix the meniscus to the back wall. And then there's one part that's open in the front. We're going to fix the anterior horn. So I fixed the anterior portion now of the meniscus, and then I'll fix as much as I can. And then you'll see the final one. I have one more cool video to show you guys. So you can see, look at that. So meniscus is well fixed. Well, how does that look at a year? Well, lucky for you, the same guy that did the surgery video, I got to do a video of his scope afterwards. So 47 years old. So this is not a 22-year-old. He had good alignment, and I evaluated his knee for something else, and I decided let's put a scope in there and look at it. I can tell you right now that even someone who's in the surgical field would not know that's a meniscus transplant. Meniscus completely healed, no tears. The only way I even knew that it was a transplant is because I did the surgery, and I saw that tiny little suture there. So that's pretty impressive. He's doing really well. So meniscus transplants, it's in symptomatic patients less than 50 years old. So you have 38 patients here. Mean age was 30 years old. So most of my patients are in that range. And again, you have 77% pain-free with low impact activities. So again, there's certain patients that don't do as well with higher impact activities, but these patients are very happy because they're no longer in pain. How about this? What about older than 50? Can we push the envelope? Well, I'm not fully there yet, but this is a good study showing that. So 26 patients had meniscus transplant that were over 50 and 26 that were under 50. They're all soft tissue, 7.3-year follow-up. And you can see both significantly improved. So this is a procedure in certain situations. We can push the envelope and maybe do 50, 55, et cetera. The only problem is it's a much higher failure rate. So 31% failed in the older group versus 15% in the younger group. But again, the only other option in someone over 50 with continued pain is either an osteotomy, which people don't usually like to do, or a knee replacement. So if I can do this and tell you 30% failure, that's actually not that bad. And again, survival rates were pretty good, almost 12 years for both the older and younger group. Now, again, these patients are very selected, no cartilage defects, good alignment, very healthy, very athletic. It's not always the case for most patients. When they get to be about 50, they have no other issues inside their knee. Well, does age affect it? Well, age cutoff here was 43. So you can see above 43 had a little bit worse overall survival outcomes, but here's the problem. when you control for cartilage defects. So as we get above 40, 45, we start getting small holes in our cartilage that we don't even know about. If you get rid of the cartilage issues and make them the same, if good cartilage and alignment with more recent meniscectomy, consider no matter the age. So when they got rid of that cartilage problem, which is more common in older patients, the numbers were equal. And so that's the point. If everything is equal, the age does not matter. How about high level returns? This is 13 patients. Again, Brian Cole, 19 years old average, 3.3 year follow-up. These are high level athletes, 77% return to sport. Okay, and these are high level sports. 23% required further surgery. It's the same as a cartilage transplant. It's usually a little meniscectomy or a small cleanup. The ones that failed, one had a meniscectomy, one had a repair, and one had to have a revision transplant. Well, how about this area? Let's talk about this. So 24 studies included, some high level stuff. There was, again here, there was no evidence that it was needed after mastectomy to prevent OA. So it shouldn't be the first thing you do to try to prevent someone from having arthritis. The successful outcomes were at 7 to 10 years, 7 to 14 year follow-up. The failure rate was 10 to 29%. And again, failure rate in certain studies is just needing a cleanup. So it doesn't mean that the whole meniscus failed. Return to sport, again, very high in the right patient, 75 to 85% success. This is a surgery that's very complicated. It's a complicated patient population. They've tried a lot of other things. They get very desperate. So the fact that you can give them a 75 to 85% success is really good if you're done properly. And again, it may prevent progression of cartilage damage in the long term. So that's what we really want to do if people start being symptomatic. Again, 89 patients here, average 38 years, 74% return to sport, around 8.6 months. This is not a 2 or 3 month recovery. How about in younger patients? This is adolescents. Again, I try not to do this if I can, I try to wait out as long as possible, but these patients, this is a high level provider, Brian Cole, again, doing these 37 patients, 11 out of 15 had open physes, so they were still under 16 or 15 years old. They had 84% lateral meniscus, which is most common because that's a discoid for them. 7.2 years, then a 22% reoperation rate, but no revision meniscus transplants needed. So that's pretty good, especially in a patient population that at that age, they'll continue to wear down their cartilage pretty quickly, and you hopefully save them from a knee replacement at a young age. And here, how about when we combine them? So a lot of times we're doing a combined surgery. So 100 patients, half had a meniscus transplant, half had a cartilage transplant, had a meniscus and a cartilage. Usually it's medial femoral condyle in this situation, no difference in failure rates or reoperation rates. So that's really important. If done for the right indications, such as you saw with the ACL, if you do all the stuff together, the rates are better. But if you miss it, it's a big deal. So that's why you want to make sure you're doing the right surgery for each patient. And don't be afraid to do more surgery if you need to make sure that you get the right alignment. And I know that's scary for patients. They're like, well, I came in here to maybe have a meniscus transplant. I'm like, well, now you need an HTO and you need your ACL redone. That's very shocking to people, but I'm only doing that so you get the best outcome, because if I do that, I can bring you to the same level as you had if you had a simple surgery. Okay, again, looking at diseases of the cartilage. So 2 groups, meniscus transplants with no defect or meniscus transplants with a cartilage defect. And again, 91 patients, 22 had no defect, 69 had a defect. There were no difference in failure rates, reoperation rates when the cartilage defect was corrected. Now, again, you're going to see here the word femur. When it's a tibial defect, it's a different animal, but with a femur, if it's treated at the same time as the meniscus, the results mirror isolated meniscus transplant. Okay, well, how about high tibial osteotomy? I always get these limb alignment films and people think that's silly. They're like, what are you doing? And I said, this is important, and you'll see why. An HTO with a meniscus is much better than either in isolation. So when you take the pressure off the meniscus, you can see here in the green is the amount of pressure per contact area. You significantly drop the pressure on that side where you're trying to protect. So if it's on the inside of the knee and the patient is sort of like this bent and you straighten them out, you will take a significant amount of pressure off. And sometimes that's more important than the meniscus transplant alone. And that we're saying now, even after seeing this, that maybe even people without straight knees should be aligned more towards the outer area or in valgus so that they can protect their meniscus transplant. That's a little extreme. I usually do it if there's a correction needed, but this just shows why you have to do the osteotomy to protect your meniscus transplant. And how about complications? We've talked about this again. The most common complication in 60% of patients with a meniscus transplant is a tear, a small tear of the allograft. Doesn't mean the whole allograft is destroyed, but what it does mean is sometimes you have to go back in there and do a cleanup. And the second most common is you have a little damage to the cartilage transplant, or is a little damage to the cartilage you have to clean up, for the most part. Failure rate's around 8.7%. So that's important to understand. And we can do a revision if we need to in the right patient. And again, here are survival rates. This is what I quote patients: 32% at 21 months, 60% again were debrided. So it's not that big of a surgery. Obviously, it's unfortunate you have to get a second surgery for this, but it's not like it's the whole disastrous destruction of the cartilage or meniscus portion. How about if we revise you? Well, if you have a transplant already, hopefully you don't have to see too many of these and have to have a second revision, but they do pretty well if done in the right situations. No progression of arthritis in these patients, 4-year follow-up, around 76% satisfaction. So that's pretty good for a very complicated patient population. So hopefully we're in good time. So conclusion, so biologics can be used individually or in conjunction with a surgical procedure. The best data is on PRP. Stem cells have less data. Again, I still do this for some of my professional athletes, but really the PRP is the mainstream. So hopefully in the future, we'll have better data on stem cells. Cartilage preservation has been very successful with the right indications. He's got high longevity and high return to sport, again, if done for the proper person. Meniscus transplant in the right patient also has good success. And we've seen high return to sport and good longevity after 10 or 15 years, which is great for these sort of patients in their mid-30s that need this. And I can get them past 50. And if they need to have something else done, then that's a lot better situation than in their 30s. Well, hopefully you guys enjoyed the talk. Sorry, it was a lot of information. I talk fast, but I want to make sure that you guys got to have full breadth of this because it's pretty complicated and it's kind of fun to learn about it. There you go. Thanks.
Thanks, Dr. Garcia. I really appreciate that. That was phenomenal information, and you packed a lot into the 30 or 45 minutes there. So, if in the next few minutes, if anybody has any more questions specifically for Dr. Garcia, just shoot them in the Q&A feature at the bottom of the screen. It's interesting you touched on microfracture because it seems like 10 to 15 years ago, I was getting all kinds of scripts from docs, saying that they had microfracture procedure and non-weight bearing or partial weight bearing. And it just dawned on me that, the last probably 6 to 10 years, I don't see that much anymore. And it sounds like it's, from what you mentioned, it's not as relevant in the orthopedic surgical world. And they've kind of moved on to some of these other techniques. Is that correct?
Yeah, that's 100%. I mean, the problem you have is that microfracture, if done properly, has the exact same postoperative protocol as a cartilage transplant. Now, I've seen some people still in the city and area, they do a microfracture and let the patients walk right away, but that's not the way you're supposed to do it. It's supposed to be 6 weeks of non-weight bearing. And so if you do it properly, it's like, why would you do that when you have another option that's much better success rate? And so I think people are starting to go to that. And they also see that just debriding a cartilage defect is pretty effective. So yes, it's fallen out of favor. People still do it. Hopefully this talk will encourage people to do less of it and focus more on taking care of the right problem. Great.
With meniscus transplants, what have you seen being the greatest range of motion limitations? Do most of your patients have normal like 140, 145 flexion and full extension, or do you see sometimes some limitations in what they're able to achieve from range of motion standpoint?
Well, the good news is patients can start bending their knees right from the beginning. So I usually have them start PT at a week and try to get their motion back. I mean, with a meniscus transplant, there are some limitations. Sometimes patients don't get back that 130, 140 degrees of flexion, but that's sort of par for the course with any major surgery that I do. Even ACL, sometimes I'm seeing patients not get back to the full, I can touch my heels to my butt type of thing. But I've seen a lot, majority of my patients do get back full range of motion, and that's important to me. So if it's done properly, they should usually get most of it back.
Great. We had a question just come in. Is a medial meniscus transplant a consideration for an older patient with osteoarthritis in the knee?
That's a great question. So I touched on it very briefly, but that is actually a contraindication to have a meniscus transplant. If you have arthritis already, so arthritis is all relative. Arthritis means you've got some changes of the bone, you've got flattening the cartilage, both your tibial and femur are affected, and then that person's not a candidate for a meniscus transplant. If you're younger and you have a cartilage defect, sometimes doctors call it arthritis, but it's actually a cartilage defect. And I can do both of those things. I can do the meniscus transplant and the cartilage transplant. And like I was saying before, those patients do really well with the proper indication. But when most people see, and they see an x-ray, they see loss of joint space, they see that it looks like arthritis, those patients do not do very well with a meniscus transplant. They basically destroy it because it's not like a smooth gliding surface. You have this sort of roughened cartilage over a fresh transplant that's not really a normal meniscus, and that tears it up.
Got it. Now, is it, would you say, is it too early to tell with meniscus transplants or even some of the cartilage restoration treatments that it can actually prevent a total knee replacement in the future? I know it's very individual for different people, but would you say you've seen some cases where, you know, people have had these, you know, maybe in their 40s and 50s and have been able to do quite well over the next few decades?
The answer is I would say yes. I mean, I don't think that I think if you've had, you know, some of my patients come in with 5-10 years of pain, and they've had no meniscus, and all of a sudden now they need to transplant, and they thankfully haven't damaged their cartilage. You know, those patients I think have good longevity, and we're able to keep them doing well and prevent knee replacement. Again, we don't usually follow them past 60, 65 years old. But if I can keep someone to sort of a standard knee replacement age at like 60, to me, I think that's a pretty good thing. And then most of these patients are 30 and they come in the office limping almost like crutches, or they talk about how they can't do their daily activities. And this is a young 25, 30-year-old, and you're like, I have to do something, and I'm not doing knee replacement. And this is an option we have for them, and it's been really successful. I mean, again, it's not for everybody, but if you do it the right way and you take the time and you do the right procedures on them, you can have good success rates. You know, there's complications that occur with anything, and I'm used to that. I take care of a lot of complicated things, but this is a really innovative technique, and just understanding everything is really important.
Great. From the rehab side of things, I know we have a lot of PTs that are on the webinar now, and we'll be watching this in the future. You know, there's research out that shows that after a scope, there's, you know, 30 to 40% drop in quad strength, and even about a year out, there can still be a difference of, you know, 10 to 20% sometimes in terms of quad total quad strength. Is there anything that that you found or you like to encourage physical therapists to kind of keep their eyes on? And it's, you know, it's important for patients to seek out when they're working with a therapist to get that strength back, because ultimately, you know, you fix the issue, you fix the problem, but they still need to make sure that their forces are adjusted and attenuated and corrected as much as possible biomechanically, you know, with their hip strength and their core strength and their ankle mobility, things like that, so that we're not putting the same amount of pressure and stress in those same areas that were repaired. So, and I know you work with a lot of rehab professionals, so I'd love to hear your comments on that and what you find helpful for your patients.
Yeah, so I mean, I said this before the talk, but you know, my surgery portion, maybe 2.5 hours, maybe an hour of work, but you guys have a way bigger job. And if the PT doesn't go well, my surgery doesn't go well. And so it's really important that the therapists do what they're going to do, and they know what they're doing, and they do. I have a lot of good therapists around the area that take care of these transplants that get me really good looking results. And again, I'm only going to take like 30% credit for it, because it's mostly you guys. And I think that the one thing I tell them is, like, you got to work. Don't be afraid to bend the knee. Like when I finish that surgery on any of those patients, I bend them all the way to 90 degrees and I bend them back. So they are stable. You should not damage any part of the meniscus or cartilage transplant by bending the knee to that level. So that's the one thing I think PTs get a little bit nervous about, especially since you don't see these patients as much. But again, that's in my PT protocol. We do usually non-weight bearing for a few weeks for each one of these procedures, and that's rough for the patients. But as long as they see a good therapist right away, that's important. In terms of the quad strength, I'm a big proponent of BFR. Usually, like you guys say, usually you start at 6 weeks. I think that's really helped. But when I see problems with my patients in the early post-operative period, it's that people are afraid to bend the knees. So as long as they get good motion and they're doing their BFR work and other quad work, I think that's really important.
Awesome. And I know you talked primarily about knees today. Do you use any kind of these cartilage restoration procedures in other joints? I know you maybe just briefly touch on that. I don't know, you don't have to go deep into any of this, but tell us what else you're doing with the cartilage restoration.
Hopefully you didn't open a can of worms. I'll try to be brief. But yeah, one thing you didn't see I snuck in there was a distal tibial allograft. So it's an ankle bone, and you saw there was a cut there. So you can go on my website and see one of the videos I did. But basically, we do that for people that dislocate their shoulders. I'll actually put a piece of the ankle bone on the front of the shoulder. And that's a cartilage restoration, because people have this defect in their glenoid. They may be missing this much, like the pinky finger, or 20% or 30%. And some of us I do Latarjets as well, but this procedure can add more cartilage to it. So we're starting to think, should we start doing more of these? Because it's more of a restoration than the actual Latarjet, which sort of just changes the mechanics of the shoulder. There's people with holes in their cartilage and their humerus, so I'll core out a piece of cartilage and plug it back in there for the young patients. And then for the elbows, a lot of the kids get elbow OCD, so I'll use a fresh cartilage graft or take a graft from their knee and plug it in there. I don't do as much of the ankle because I have a foot and ankle partner that does a really good job, Dr. Mark Reed, and he'll do cartilage transplants of the talus. So you can transplant a lot of different body parts. We are just starting to think about the hip. The hip's a totally different animal. I've only done 1 or 2 of those, but overall, that's a next generation of stuff we're talking about. But yes, fresh cartilage transplants are becoming more and more popular as insurance companies are authorizing it. It's the most commonly done thing, most commonly authorized thing for the knee, occasionally in the shoulder, more in the ankle, and then we have elbow stuff. So.
Wonderful. So it sounds like on the horizon in the next 5-10 years, there'll be just you know, the cartilage transplant, the fresh cartilage transplants will be possibly expanding to more joints outside the knee. Anything else that you see is, you know, from your perspective that may be coming down the pipe to offer to patients in the next 5-10 years?
Yeah, I mean, I think the thing is you got to look at Europe. I mean, they're way ahead of us. They always get to be more innovative, unfortunately. We like to think we know what we're doing in the United States, but those guys are definitely pushing the envelope. So for the meniscus, there's scaffolds. So what they do is they have these sort of like just a template, and then like they have stem cells and cartilage cells that grow in there and can actually remake a new meniscus, which is really cool. Wow. And that's they've even done it where they've taken parts of the meniscus. Let's say you're torn half of it, and they sew that in, and the new grows back. So that's one thing that's going down the pipeline. The next thing is how we combine biologics and meniscus stuff. So how can I put in stem cells or PRP or whatever into your meniscus transplant and take it from a 30% complication rate because you get a tear to a 15%. And then with the cartilage, and I've done some consulting for some of these groups that have like this, you just plug this like plug in, and then actually has all these factors that cause it to grow right up to that level. So there's all these fancy cartilage things. In the next 10 years, I have a feeling that this will still be a pretty good mainstream, but there's going to be some other things coming down the road that are going to help patients. We're just going to keep getting better and better. The thing the ideal thing would be, you hate to say this, is put the knee replacement guys out of business. Is you basically have everybody has good cartilage. I don't think that's going to happen, but again, if I can help more people and do these techniques to try to save people and keep them active and younger and moving better, that's ideal for me.
Awesome. Well, you know, this is very helpful information, and I know the viewers got a lot of information from this too. You know, on behalf of Lake Washington Physical Therapy, we really appreciate your time, expertise, and, you know, taking care of our patients in our community, Dr. Garcia. So thank you very much. The recording of this webinar will be on our YouTube site, and we'll push this out to some of our social channels as well. And you'll be able to find it on grantgarciamd.com. Dr. Garcia, any final words, or you want to let the viewers know how to best reach you?
Great. Well, first off, I want to thank everybody for tuning in and bearing through that talk. It's a lot of information. It's kind of overwhelming, but now you know how my patients feel when they come in for the first time and we're told they need something like this. So, but anyhow, thank you guys so much for having me. This is an amazing opportunity. Again, Lake Washington Physical Therapy, they're amazing. You guys make sure you tune into them. And then on my website, you can find more information. So it's listed right here, grantgarciamd.com. I'm also part of Orthopedic Specialists of Seattle, so you can make the appointment there if you want to see us. If you just want to chat about something you're concerned about your knee, I'm happy to see you as well, or shoulder, whatever you need. So thanks again for the opportunity, and I look forward to helping people out.
All right. Thanks, everybody. Thanks, Dr. Garcia.
Thank you.